Hey everybody, this is Mrs. McDaniels, and we're going to just touch some highlights through these endocrine function disorder presentation. I'm going to focus more on the topics you need to know and less on the ones you don't, but I'll hit the highlights of what you need. This just gives you an overview of the different organs involved in the endocrine system. Patient assessment. What's difficult when there's an endocrine disorder is that lab work typically needs to be done in combination with reviewing a patient's symptoms. Starting off with pituitary disorders, you have your anterior and posterior pituitary, and it's typically going to be an issue of either oversecretion or undersecretion. Remember that your posterior pituitary stores hormones, and the one in particular that you need to focus on for this class is antidiuretic hormone, where your anterior pituitary can actually create hormones. So your posterior pituitary stores where your anterior pituitary actually can create. With pituitary tumors, typically signs and symptoms that patients will have is headache and visual changes. And it actually creates pressure, intracranial pressure. Usually there's different types. The most common are caused by secretion of prolactin. Diagnosis a lot of times need to be done with the history and physical CT or MRI. Surgical management will be actually removing the tumor, so it's called a hypothysectomy. Management will be overseeing the patient before and after, some different medications, pre and post, providing steroids, thyroid hormone afterwards. Accretotide is a medication that can help control some of the symptoms that the patient is experiencing that can be provided beforehand, and that accretotide sometimes you will see on ATI tests. Management preoperatively is to increase intracranial pressure. Afterwards, reducing cerebrospinal fluid leaks. So make sure that you know the education for this, and also how to monitor for CSF leaks. Clear drainage from the nose or the ear. It's usually going to be just one nostril, not both. And the halo ring test. Basically, if you look at somebody's bedding, a lot of times there will be a halo. Let me see if I can manage to draw this without breaking it. So you may see, like, say on their bed sheet, you see a little bit of red drainage. It's kind of like a halo. And then just around it, you'll see very mild hint of like yellow in this area, and that's basically glucose that is from the CSF. So sometimes you might see that ring, which could be an indication of CSF leak. And also you want to do oral care and watch a patient's weights. So this is one of the conditions that you do need to know. Cushing's. So you will see this again, kind of a deja vu moment later when we get to adrenal disorders. But this is going to be an oversecretion of ACTH, which is adrenocorticotropic hormone from the anterior pituitary. That stimulates the adrenal cortex to overproduce cortisol. So basically, it's a disorder that's characterized by high levels of serum cortisol. Signs can include an arrest in height, so shortened, obesity, musculoskeletal changes, and glucose intolerance. As a nurse, you need to promote safety, help prevent infection, watch a person's skin integrity, and a lot of times these people are not going to be very happy with their physical appearance, especially if they've had Cushing's for a long time. So some things you may see. Descriptors: moon face. They're usually at a higher risk of having hyperglycemia, because remember, cortisol inhibits, doesn't really allow insulin to do its job, but it also stimulates the liver to create more glucose. We're going to have some sodium and fluid retention. We're going to have higher risk of bruising and petechia. They're at high risk for osteoporosis. But also you're going to see some strange fat deposits on the face and back of shoulders. So another one you may have heard is like a buffalo hump on their back. So let's see here if I can get out of this. Let's see, is the following statement true or false? If they've been taking corticosteroids for several years to treat an autoimmune condition, is the patient at an increased risk of developing Cushing's? Yes, it is. Acromegaly, really the only thing you need to know about this. Oversecretion of growth hormone from the anterior pituitary. That's it. Acromegaly is going to be the term used with adults. Get it? Adults. Gigantism will be used when we are talking about kids. Diabetes insipidus. This could be a history of head injury, pituitary tumor, or injury from a craniotomy. This is basically when there is an undersecretion of ADH from the posterior pituitary. Remember, like I said, the posterior pituitary is going to involve everything with ADH. So the problem is antidiuretic hormone. Basically, this is what regulates some of the fluid in the body. And so if your body is not producing this, this is what's happening. You are losing copious amounts of fluid. So signs and symptoms, up to 20 liters of urine a day. This patient will have a lower specific gravity, lower osmolarity, hypovolemia, increased thirst, tachycardia, and lower blood pressure. Okay. And this is going to be, let's see, when it says lower osmolarity, this is going to be lower urine osmolarity. What you want to watch is monitor their fluids, replace your fluids, check their neural status, watch vital signs, and if they're dehydrated and truly dehydrated, they're going to have warm, dry mucous membranes. Types and causes. You really don't need to know the 3 types, but just understand it can be neurogenic, nephrogenic, or psychogenic in nature. And the psychogenic one is basically when somebody has resulted in excessive water intake. Neurogenic, neuro, think brain, head trauma. Nephrogenic, it can be damage to the tubules, and in terms of failing to respond to ADH. Diagnosing, a lot of times you're going to see the amount of fluid coming out, nocturia, decreased specific urine gravity. You're going to have an increased serum osmolarity, like I said, where you'd have a lot of thirst going on, so make sure you remember your signs and symptoms of fluid volume deficit, or hypovolemia, so tachycardia, my mind's gone a blank at the moment. It'll come back to me. Tachycardia, low blood pressure, well, you wouldn't have olguria with this just because the body's not responding to the ADH. So this is going to be the exception where you're going to have that fluid volume deficit. But unfortunately, the person cannot manage the dilution of all the water that they are losing because of the decrease of ADH. So ultimately, what do you think is going to be the solution to fixing it? Just think about it for a second. Diagnostics: give the patient a vasopressin challenge test. You can also do a fluid deprivation test, but this shouldn't be done if the patient is already hypernatremic. Treatment: well, if they're lacking this, we need to replace it. The synthetic is called vasopressin. Watch daily weights of this patient. It can be given intranasally or by injection. Other things that do seem to help, they're really not sure why, but thiazide diuretics can also help. It helps the effectiveness. And prostaglandin inhibitors also seem to help. And just go through this question here. So, syndrome of inappropriate antidiuretic hormone. Basically, this, I always think inappropriate, is that it's just giving it way too much. So this is where the body has an oversecretion of ADH, so they're holding on. So they're holding on too much fluid, they're overloaded, high blood pressure, tachycardia, high specific gravity, very concentrated urine, and a lot of times these patients are going to need fluid restrictions. And the problem is that they can't rid the body of dilute urine, so its retained water can develop subsequent dilutional hyponatremia, which is really important to know. Factors, a lot of times they are non-endocrine in origin. Make sure you just know your signs and symptoms of fluid volume overload. Patient might also be hyponatremic because of the dilutional hyponatremia. Decrease serum osmolarity. Increase urine osmolarity. Urine sodium over 20 milliequals. If the patient has severe hyponatremia, they might have more severe symptoms. So if that's the case, they probably should be on seizure precautions. Weight gain and change in their level of consciousness. Treatments, seizure precautions. This is the one condition that you will use a hypertonic solution if there is severe hyponatremia. One thing you want to watch is monitor for hypertonic saline administration to prevent central potent myolysis. Basically is a neurological disease caused by rapid changes in the osmotic pressure, so you need to be careful when you are actually administering the solution. What type of IV solution is appropriate for a patient with SIADH? Hopefully you remember that you want a hypertonic solution like 3% sodium chloride. If you need a break, go ahead and take one. This is a super awesome, cute comic strip. It says, "Thyroid, my liege, the organs grow weary. They require more hormone. Silence, sir, silence." So they definitely need more hormone. Speaking of which, thyroid disorders. When you think thyroid, please, please, please think metabolism. So assessment, again, lab work to determine any hormone changes. Hypo, think about everything slowing down. This is going to be a decrease in T3, T4 production with high TSH levels from the anterior pituitary. Manifestations are divided into early and late symptoms and really can represent slowing of the metabolic process. So look at your different symptoms here: intolerance to cold, fatigue, thick tongue, slow speech, anorexia, and even though there's anorexia, there's weight gain, which is terrible. brittle nails and hair, changes in menstrual cycle, constipation, muscle weakness, lethargy, apathy, and hair loss. Light clinical manifestations, subnormal temp, so low temps, bradycardia, weight gain, LOC changes, thickened skin, and cardiac complications. Autoimmune hypothyroidism is known as Hashimoto's, so when you hear Hashimoto's, think autoimmune. That's basically when the autoimmune decides to attack the thyroid. Radiation treatment for hyperthyroidism, if thyroidectomy, head and neck cancer with radiation treatment. Unfortunately, females between the age of 30 and 60 are at higher risk, and really screening should be done for women over 50 if one or more symptoms are present. The myxedema coma is basically the most extreme severe stage of hypothyroidism, and typically this can kill somebody. So when I talked about hypothyroidism, think slowing, think turtle, and basically think somebody slows down so much and everything becomes so depressed that they go into coma. And there is a high mortality rate with this. Treatment, hormone replacement, this is lifelong, so this is something a patient will just have to work through and acceptance because they'll have to be on lifelong. Synthetic, either levothyroxine or Synthroid, which is the brand name, which is basically synthetic T4. Because the process basically is from the anterior pituitary, TSH basically will then stimulate the thyroid to create T3, which goes through the process to create T4. Want to watch cardiac, especially in your geriatric patients, especially with those with long-standing, can lead to some cardiovascular. So anytime you start medications with them, you want to start low and go slow. Nursing management kind of depends on the state of the patient. Watch their physical status. Sometimes, just because the metabolism is lower, their liver can get a little sluggish. Medication education, this is important, what you need to know for testing or for the rest of your life as a nurse. Caution with narcotic administration can increase the sensitivity. Thyroid hormone can increase with fentanyl and increase certain other drugs like digoxin and anticoagulants. If you haven't learned, digoxin seems to be affected by just about every medication. It needs to be taken on an empty stomach. It needs to be taken at the same time each day. And also there needs to be consistency with formularity by a pharmaceutical manufacturer. Make sure your patient gets up and moving and help him with coping because, like I said, this is a lifelong change. Hyper is going to be the flip. Think of increased metabolism. This is basically when there is overproduction. So look at the signs and symptoms. Intolerance to heat, fine straight hair, bulging eyes. This is something that cannot be reversed with treatment. So patients with long-standing, this is going to be a lifelong problem. Flushing, enlarged thyroid can lead to a goiter, tachycardia, increased systolic blood pressure, breast enlargement, weight loss, muscle wasting, because again, metabolism is completely sped up. Can have some localized edema, menstrual changes, increase in diarrhea, tremors, finger clubbing. These people are very, very, very agitated. Agitated. And I can't even spell that out. Agitated. Oops. This is like miserable doing it on a keypad. Agitated. As horrible as that looks, my point with that is if you get one of these patients in the ER, you need to put them in their own room, turn down the lights, try to give them a calm environment because anything that would agitate your eye is going to agitate them even worse. So, Graves' disease is a type of hypothyroidism. This is the autoimmune version of it. So if you hear Graves, that is because antibodies have actually bound to TSH and have caused an overproduction. Again, women, you see a lot higher in those, are often caused by stressor infections. I've seen a lot of patients where if they have this, pregnancy was the cause of it. Other causes can be thyroiditis. Thyroid storm basically is going to be the critical condition of hyperthyroidism. Patients usually present with high fever, significant tachycardia, exaggerated symptoms with major disturbances, weight loss, abdominal pain, diarrhea, cardiovascular in terms of edema and chest pain palpitations, and also they can appear delirious and have some psychosis. Treatment: radioactive iodine, because iodine is one of the components needed to create thyroid hormone. So when you put radioactive iodine into a patient, it will actually go and destroy the thyroid. It's the most common treatment for Graves. Other medications can be used, antithyroid drug therapy, which will prevent the synthesis of the hormone. The biggest side effect of that is granulocytosis, which decreases the number of granulites. It is contraindicated in late pregnancy. Patients can have their thyroid removed. I'm going to talk a little bit more about thyroid storm on the next slide. But in terms of basic patient care, nutrition, like I said, provide a calm environment, watch their body temp, glucose monitoring, because it can kind of run the liver kind of into the ground, eye care, especially with the exothalamus, and education about signs and symptoms of infection while on an antithyroid drug therapy. And we'll talk about some of the anti-thyroid drugs on the next slide in terms of thyroid storm. So for thyroid storm, signs and symptoms: high fever, tachycardia, like I said, exaggerated hypothyroid symptoms. What you need to know about treatment is some of the symptoms that are kind of kicked off from having that over-exaggerated metabolism. So primary objectives, symptom-wise, are decrease body temperature, help decrease the heart, and with that prevent vascular collapse. Okay. Ways to do this: get their body temp down, cooling blanket, bear hugger, cool environment. Tylenol can help with that. Monitor glucose levels. Aspirin is to not be used. This is a big one. It displaces binding proteins and makes the hypermetabolic state even worse. So that is a big no-no. Give the person oxygen. Again, hypermetabolic state, kind of the body will burn through all of its reserves. IV fluid with dextrose, because it kind of peters out the liver. That helps to replace the liver's glycogen. So the two medications that are used, antithyroid drugs to basically block T4 to T3, is either PTU or methimazole, and methimazole is typically first choice. You want to give a patient beta blockers that will help with the heart rate. See down here. Hydrocortisone, basically to help to prevent shock or adrenal insufficiency. And large doses of iodine can also be administered to diminish the output of T4. Causes of goiter: lack of dietary iodine, high levels of TSH, Graves or Hashimoto's disease, nodular goiters, thyroid cancer, pregnancy, and inflammation. This is not so much of a problem here in the United States as in some other underdeveloped countries. Here's a side-by-side view between hypothyroid and hyperthyroidism. What medication should never be used with a patient with hyperthyroidism? And I hope you say aspirin. Parathyroid disorder. First, think about what does the parathyroid do? This right here, it talks a little bit, gives you the feedback loop. It's involved in the regulation of serum calcium levels. Hyperparathyroidism is basically an excess of parathyroid hormone, which can lead to increased calcium levels. So think hyper, high levels, high calcium. And this just kind of gives you an overview of the symptoms that you may see. Diagnosing, it's going to be the same as hypercalcemia, so stones, bones, moans, and groans. So hopefully this should be pretty easy when you are thinking back to your last unit. In terms of management, if somebody already has high calcium levels, you want to go ahead and help with hydration therapy. pH can help lower urinary pH. Avoid thiazide-diuretics because they can actually decrease the secretion of calcium. If somebody's in a crisis, to help get those lower, remember that phosphate kind of does the opposite. So you can give a patient phosphate therapy. Steroids can also help, and just with almost everything, monitor their heart. Avoid dehydration. Make sure you educate your patients about renal stones and encourage mobility. Hypoparathyroid, obviously if hyperparathyroid was high calcium levels, hypo will be low. So a decrease will lead to a decrease, oh that's awful, decrease, missing an E there, serum calcium levels. Causes surgical removal of the parathyroid gland, some genetics, heavy metal exposure, and magnesium depletion. Hypo can happen, not just removal. When I say removal of parathyroid, you will see this sometimes happen with thyroid surgery itself. And because of where the parathyroids sit, sometimes they're either damaged or removed if somebody's having a thyroidectomy. So if a patient is at risk of that, especially with the thyroid surgery, you need to know your signs and symptoms of low calcium levels and respond to them accordingly. So convulsions, arrhythmias, tetany, and spasm and stridor. Early stage signs and symptoms are vague, so lab work should be done, especially on patients when they've had a thyroidectomy. Other things you want to look at with a thyroidectomy with those patients is if they have like tingling around the mouth and hands and feet. So make sure you know your signs and symptoms. Again, because of its low calcium, patient may need to be on seizure precautions and talk to them about eating a diet high in calcium and low in phosphate, and again, cardiac monitoring. Adrenal gland disorders. So don't get confused with the adrenal gland. The cortex and the medulla have different functions. The cortex is activated by the ACTH released from the anterior pituitary. The medulla is actually activated by the SNS to reduce catecholamines, which are epinephrine, norepinephrine, and dopamine. And this is where there's some neurological regulation within the endocrine system, which, the adrenal glands, that's pretty cool. But right now we're going to talk more about the cortex. So adrenal glands, they are responsible for fluid balance because you have your aldosterone and glucose fluctuations with cortisol, and changes in both hair, voice, and libido because of the androgens. So there's a lot of things that those little glands do that sit on top of your kidneys. Hypersecretion can lead to Cushing's, which can lead to an increase of acne and hirsutism, muscle weakness, paresthesis, and also increased risk in fractures. If you're thinking about failure of the adrenal glands, think about weakness, fatigue, poor appetite, and weight loss. The medulla, again, which is more neuro, think headaches, anxiety, nervousness, tachycardia, and sweating. So, you know this name. You will see it this semester, and it may creep up again in your senior year. It's Pheochromocytoma. This is a tumor of the adrenal glands. It is a rare disease in those who, their main symptom, that they're hypertensive. And it can actually cause a hypertensive crisis. The signs and symptoms, my gosh, because the adrenal medulla is affected, you have hypertension, and this is going to be severe. Headache, hyperhidrosis, hypermetabolism, hyperglycemia, so the 5 H's. Tremor, flushing, and anxiety. Need to remove the tumor. Okay, so if you are going to remove this tumor, even though the medulla is affected, because you're removing all of it, make sure that you understand that if you're removing this, that patients are going to need replacement of their steroids. So a lot of these patients, when they're getting set up before surgery, you're going to have to replace their hydrocortisone. Addison's. So Addison's is basically when you have a primary adrenocortical insufficiency. You're going to have a decrease in some different things. And it can be all 3. It can be 2 of the 3. But you're going to see a decrease in cortisol, aldosterone, and androgens. Cortisol basically will decrease inflammatory reactions, increase fat metabolism, and raise serum glucose. Aldosterone is responsible for sodium and water reabsorption and the excretion of potassium. And androgens, well, sex hormones or sex hormones. So you can see this brown pigmentation of the skin. This is going to be some of the later signs. This takes some time. Patient can be at higher risk for hypoglycemia. Changes with having issues with hypertension. Can have some weight loss, GI disturbances, and weakness. Crisis is what you really want to prevent in these patients. They'll have profound fatigue, dehydration. They'll start to have vascular collapse. Their kidneys will start to shut down. Their sodium levels go down, and their potassium levels go up. So if you think about if somebody has low sodium and high potassium, what are you going to want to monitor? What are their EKGs going to look like? Are they at risk for seizures? So do they need to be on seizure precautions if they're going into crisis? Types, autoimmune or secondary. Risk factors obviously can be from TB to having removal, prolonged daily administration of corticosteroids, because again, sometimes, if you replace something, the body will kind of stop its own administration of it as well, which we also know that prolonged can also lead to Cushing's. Signs and symptoms, muscle weakness, GI, fatigue, emaciation, skin pigmentation changes, and this kind of really talks about it right here. We're going to talk about the pigmentation. High potassium levels, low sodium, depression, emotional lability, apathy, and confusion. Crisis, you'll see severe hyponatremia, severe fluid volume deficit, acute hypertension, cyanosis, circulatory shock, headache, nausea, abdominal pain, diarrhea, confusion, and restlessness. And somebody can be in crisis and not have all these symptoms, or they can feel that they're going into crisis. Medical treatment, treat the circulatory shock, help boost that circulatory load, give them fluid, give them steroids, watch their vital signs, put them in a recumbent position with the legs elevated. You basically are trying to promote fluid back to the core. Vasopressor for hypotension. Basically, you want to try to get them out of this hypertensive state. Antibiotics if there is an infection, because sometimes it can be the cause of adrenal crisis. So again, look for the root cause. Talk to patients about having diets high in sodium, especially during times of GI disturbance and in hot weather. Hormone replacement, especially during stressful times, illness. That means that they might have to need some additional corticosteroids in terms of times of illness, and to stay away from patients with infections, strenuous activity, or stressful situations. Again, crisis can lead to that vascular clamps with signs and symptoms of hypovolemic shock. Cushing's, oh my god, it came back again because, as I said before, it's a pituitary disorder, but the issue can also happen right with the cortex. So we can have an issue with the adrenocortical hormone from the anterior pituitary, or it can just be an issue at the cortex that just it overproduces cortisol. What you need to watch, especially in women, you may see virilization, basically some masculine traits, and the recession of feminine traits, visual disturbances if a pituitary tumor is present, overnight dexamethasone suppression test. Patients may also have decreased serum potassium. But at least for you, you want to promote safety, prevent infection, skin integrity, and body image. And also, too, sometimes it can be an overuse of steroids, and they may need to reduce that. And sometimes they actually remove part of the adrenal gland if there's hypertrophy. So this is a side-by-side comparison of Addison's when there's not enough steroids, basically, where with Cushing's there's too much. So this is just some of the highlights. We'll talk a little bit more about things in class, but should give you a good start, and hopefully have a better idea of what you need to learn, where you should put your focus, and we'll kind of go from there. So happy study times.